Good afternoon, everybody. I'll be speaking and proposing a modified pediatric ocular trauma score as a novel scoring system in pediatric penetrating injuries. As we all know, ocular trauma is the second most common cause of referral for kids after strabismus in this age group, and pediatric eyes are just not a small adult eyes. There are so many problems with the pediatric eyes, because of which we always get a delayed presentation. Now, OTS is something which we all know, which was present, which is a standard of classification system by Ferenc Kuhn, and this has been being followed for adult with all these parameters being understood with a raw score, some with raw points, and whenever we have a certain score, the prognosis is understood. Now, because of in pediatric eyes, a different kind of classification was proposed by Akar et al., where they did not consider RAPD, and visual acuity at presence was not necessarily taken, whereas a score was considered from the rest of the points. So what is actually not considered in this pediatric ocular trauma scoring system is full thickness corneal tear, intraocular foreign body, and lens status. Either lens is dislocated or it is expelled out. So we decided to evaluate a novel modified pediatric ocular trauma system, which uh, which will be used as an important tool for prognostications of visual outcome in pediatric patients. Whenever the kid is brought by the parents, they are always asked, "Doctor, will my kid see?" And this will be an all-encompassing scoring system where all the points, including the missed out points, will be considered. This was a prospective study for 2 years, and these were the inclusion criteria. Kids who completed 2 years of follow-up, 50 eyes of 50 patients were included in this, and visual acuity in logmar scale at presentation and at conclusion was noted. Location of the wound with respect to limbus and concomitant eye pathologies were noted. These were the parameters as per POTS, that is pediatric ocular trauma system. But what we considered in addition is full thickness corneal tear, intraocular foreign body, dense dislocation, leg dispulsion. Now, the most important point here is whenever we have full thickness corneal tear, we always get some kind of astigmatism and leading to amblyopia. Same with intraocular foreign body, it will lead to inflammation and it will cause a secondary membrane and those sort of things which have a long-lasting effect. And lens, of course, if the patient is aphakic, as we all know, amblyopia management is going to be a big challenge. So we incorporated these into this scoring system, and this was the scoring system added to the existing scoring system. Now, when we prepared the raw points of the summation, these were the modifications done. Higher the score, better is the visual acuity. Our study had 56% males and 44% females. Mean age of presentation about 7 years. And most common cause of injury was pencil followed by knife. So interesting point here is again corneal injuries were 66%, corneoscleral were 22%, and scleral just 12%. So it's very important to note here that the corneal involvement is very important. And this was the distribution of groups as per the raw score sum. So 7 patients at presentation had no PL, and the highest visual acuity on log more than 0.2 was 9, which finally had come up to 13. So this was the graph of presentation at final. So 88% injuries involved cornea, and this is a very important parameter which has been missed by the primary ocular trauma scoring system. So we have included this the scores into a modified ocular trauma score, which can be the standard of reference for all our prognostication of pediatric ocular injuries. So now modified POTS has the previous ocular system plus full thickness corneal tear, intraocular foreign body, and lens status, which again translates to amblyopia. And this is a better and all-encompassing scoring system as compared to the traditional POTS, and it will help us to prognosticate better in long-term visual outcomes. These are references. Thank you.
Did you actually compare the study with a proper ocular trauma score? Any bivariate analysis or something like that?
Madam, we are actually continuing with the study now, and we are about to reach 100 patients. So in this, we did a comparison analysis with the previous existing. This was the. Can you please show this slide? So we did a comparison with excluding these three, and we found that the main reason of loss of vision was one of this.
No. My question is that did you actually did the scoring in both the ways and compared?
Yes, madam, we did the scoring, and that is one
but-
of the statistics there.
But I'm not. Where is that part? Can I see it again,
Can
please?
we see
Can
the
you please
slide?
show me the slide?
You can start the slide presentation. So you can start the slide. So the other thing that I wanted to know, what you put them into groups. So what was the basis of the stratification of?
So
the
stratification was according to the scoring.
So why did you cut off at in a particular point?
So
did you
it
notice
was-
that there was something.
So
Specific?
it was according to the previous
Previously.
ocular transfer. We have a standard of comparison. Because sir, what importantly we saw is astigmatism is something. If a kid is left aphakic, now management of that is extremely important. Astigmatism. So that is why I included all these and then compared with the existing. So we compared both the previous and the old systems.
And your longest follow-up is again how much? Longest
2
follow-up?
years, sir.
2 years.
Dr. Anant.
Yes.
Ka.
Average follow-up?
Sir, we made sure that this
All
entire
of them?
data has 2 years,
2 years.
and people who did not follow up, they were excluded.
Next. Can you tell them where to stop? Yeah, next.
Which one was it, Dr. Anant?
I'll just take it.
I don't think there's a comparison.
Yeah, there's no
slide, is there?
comparison
No
that you-
comparison between OTS and old OTS.
Sorry, ma'am,
and-
I think that slide I forgot to do. There's a comparison between the
Yeah, that-
previous old
that
OTS,
is act-
pediatric OTS, and
yeah,
the new
that
one.
is
So your
actually would have
patient
proved your
as
point.
per the old classification,
Old
and your
classification
patient as per
as
the
per
new.
the
Exactly.
new.
That
Yes.
was
That is
needed.
more
That was,
important.
yes, ma'am.
Thank you.
Fine.
Thank you so
Okay, thank you.
So we'll next